Well, thank you very much, Carlos, for that generous introduction. Yeah, it was 1989, a long time ago, which is relevant to the topic, aging. It happens to all of us. I'm very happy to be here. Thanks for the weather. This is tropical weather. I was not expecting that in Chicago in April, but thank you for that. I'm also very happy because I've met a lot of you during the course of the day, and I realized that I'm actually talking to a group that is very, very inter and transdisciplinary. And this is not the usual, I would say. So that makes me happy, but it's also a challenge because the material that I want to discuss with you has different elements that may be relevant, some of them, to the work you do. Others may be a little bit distant, but this is really the way we integrate knowledge, and that's really what I would like to do today. Do you hear a sound?
There's like a little echo. Yeah.
Should I use the other mic? No? This is okay?
Okay, we're good.
Okay, good. There you go. So these are my disclosures, NIH support for different grants and research projects. Now, the topic of longevity is not new in the sense that everybody is interested in living longer. And we have examples in nature that I guess show that animals and plants can actually have a very long lifespan. The one on the left, top left, is the Japanese symbol of longevity, which is the ginkgo biloba tree, which you may be associated with a supplement that is sold in many stores. The one on the right was a discovery that was published a few years ago, the Greenland shark. And the immortal jellyfish is a different example in the sense that people argue that these animals do not die ever. So they're not, the issue with them is not longevity, but immortality. But nevertheless, these are stories that get our attention because we would like to be like them. Now, that is not really something that shows very clearly in human demographics data. You see on the slide, the yellow bar represents the 2024 data. The green bar represents the projection for 2050. And we are including here people in this age group, 65 years or over. And I would like to immediately say, be careful when you look at these statistics. And some studies use 60, not 65, but we like to use 65. So nevertheless, the message is very clear. In many countries, for example, in Europe, Portugal and Italy, you see that right now they have a large percentage of the population in this age group. But the projection is even higher, is for close to 35%. Japan and South Korea are even older, I would say, as a society. 40% of the population in Japan and Korea is projected to be in this age group by year 2050. Now, year 2050 is only 25 years from today, so it's not a century, okay? Now, in other parts of the world, the trend is the same, although the numbers are a little bit lower. So in Arab countries, projection is for close perhaps to 15 to 20%. South America, Argentina, 21%. The US is now around 16%. The projection is for 24%. Now, let me suggest respectfully to you that when you look at that number, don't think about somebody else who is aging. It is you and me. All of us will be in these numbers. So, and our patients will be there. So it's something that we should all be concerned about. I come from Puerto Rico, and as you can see, we're older than the mainland. Projection is closer to the Asian countries. In fact, Puerto Rico is the 5th largest nation or territory in the world per population, okay? 5th oldest, I should say, per population. So the message is individuals are getting older, societies are getting older, and this is happening all over the world. There is no exception to this. This is why the WHO published this report in 2014 and actually declared this decade of healthy aging, which is something that was supported also by the United Nations, not only the WHO. And their focus was not aging, older, and so on. It was healthy aging. And that's how they define healthy aging, process of developing and maintaining function. This is the key that enables well-being in older age. And how do they define function? Be mobile, move around, build and maintain relationships, meet their own basic needs, learn, grow, make decisions, contribute to society. It is not low blood pressure, control blood sugar, and so on. The concept goes beyond biological metrics of what we consider to be normal. So this was an important step because it was the first time that an international entity recognized that this is an issue, that aging is an issue that nations, governments, societies have to address. Now, I want to share with you this video that actually will show you or demonstrate what healthy longevity is all about. I think the video on the left is moving slowly, but I think you'll get the message. This is something you can call like a longitudinal study of aging. Case report, single individual study, 6 years apart. This is an old individual, by definition, older than 85. And of course, to do this, you require not only muscle strength, but also balance, coordination, and many other things. So this is really the ideal healthy longevity concept. Now, we use age, when we talk about this, age as a chronological age, as our metric. But I think we need to recognize that age per se does not determine aging. And this is one of the challenges that we have in gerontology and geriatrics. And we do not have any other way of measuring age or aging. There are some people doing research in epigenetics, developing a clock that can then be measured in the clinic and say, okay, this person has a chronological age of whatever, 75 and a biological age of 65. You see people sometimes that look older than what they are, and the other way around. And that picture on the screen is a message or a demonstration of that phenomenon. If I didn't have the numbers on the screen, you would have guessed probably that the lady on the right was older. And that tells you a little bit about our concept of age and aging. We're simply looking at aging of the skin due to exposure to the sun, of course, not to the internal biological clock. So right now, we use chronological age as an indicator of what we're trying to measure, but I think we need to keep in mind the problems associated with doing that. The real issue, however, is not that we live longer. You and I would like to live longer. The problem is that we don't have the same healthy life expectancy that we have life expectancy. So you can see the yellow bar shows the life expectancy, men at the top, women at the bottom. And you can see the two different years. In red, we have the healthy life expectancy. And as you can see, the problem is that we live probably about 10 years, 10 to 11 years, with a lot of chronic illness, impairments, problems, society barriers, and so on, that we cannot really say that this is a healthy lifespan. And instead of extending life expectancy, which, by the way, we have not been making a lot of progress in that regards, we should be trying to close the gap. And as I mentioned to a group today, I would like to live to be 80 at a very high level of functioning, and then all of a sudden die. That is my ideal of a healthy life. Instead of spending the last 10, 11 years dealing with all kinds of chronic conditions, impairments, limitations, and so on and so forth. Now, another important issue about aging is that this is not a homogeneous process. We do not have a typical older person. You look at those pictures, they are all old, older than 65, but they look different. And this is another thing that we have not been able to quantify that well: diversity, heterogeneity, variability in the aging process. But we know it is out there. And we simply are not able at this point in time to quantify it, to measure it. But I think it's important for you to keep in mind, this is the challenge of putting everybody that is 70 years old in the same study group and say, I have an old or older population. Well, you don't, because they have different characteristics. Now, one of the issues that we're dealing with in terms of aging is, as we see it in the clinic, people that lose muscle mass, strength, mobility, and so on. This is kind of a typical picture of an older individual. And in 1989, that phenomenon was called sarcopenia. And this is really the term that we're still using nowadays. The person that put together that term is Irving Rosenberg, who was an internist and nutritionist. And he was the director of that center in Boston. That's where I got my PhD. And the basic observation is illustrated on this slide. You see, these are MRI images at the level of the mid-thigh of two healthy individuals. These are not patients in a hospital. These are healthy individuals in the community. So here you have a young individual and a 75-year-old healthy individual. And as you can see, you can identify immediately three important changes. Number one, this dark tissue is all muscle. And as you can see, there's significant muscle loss. Number two, the subcutaneous fat is also increased. And number three, the intermuscular fat is also increased. And by the way, the intramuscular fat is also increased, although you cannot see it in an MRI. Now, this is a picture that is associated nowadays with metabolic illness, diabetes, hypertension, even cancer. So something that was described in 1989 as the cause of weakness and impairment is now associated with a lot of important health conditions. Scientific interest has also increased. This is the number of publications listed in PubMed. If you enter sarcopenia, do a search with sarcopenia, this is what you get. And I would say that maybe in 2010, this is 21 years after the term was coined by Dr. Rosenberg, then we started to see significant increase in the number of publications. And in 2025, there were close to 5,000 papers in the literature on the topic of sarcopenia. And entities like NIA has become very interested in sarcopenia. Now, this is publications. Now, if you think about clinical trials and you go to clinicaltrials.gov, right now, or 2 months ago, there were more than 1,000 studies that have been registered looking at treatments. These are clinical trials, interventions designed to treat sarcopenia. And as you can see, they're taking place all over the world. It's not only North America, Europe, and so there's a lot of in Asia for obvious reasons. Asian countries are experiencing aging faster than many other parts of the world. So publications, basic science, clinical trials, all of that is increasing because of the interest in sarcopenia. Now, how do you define sarcopenia? Okay, so here we have two definitions that were proposed by two different international groups. On the left-hand side, you have the European Working Group. The definition was actually published in 2019. On the right-hand side, you have the Asian Working Group on Sarcopenia, published in 2020. Now, if you look at the definition by the European group, you see that the word age and aging is not there. It's not included, which is a big change. It is a significant deviation from the original intention. On the right-hand side, the Asian group is more classical. They have maintained the age, the association with age. These two groups are kind of working together to try to come up with a consensus that everybody will use. But I don't have to tell you that if we have two definitions out there on what sarcopenia is, research is probably more difficult to compare because they don't have the same metric. The international group published this about a year ago. This is the Global Leadership Initiative in Sarcopenia. And the definition is in the center. It's more about muscle mass and muscle strength. And they've actually have eliminated to some degree the functional aspect of sarcopenia and define it as an outcome, not as the main problem. In rehabilitation, this is actually offensive, that you eliminate functioning from a definition that we think is so important. But, you know, they have their rationale. They claim that this is an outcome, not the basic problem. Now, this is still not accepted by everybody internationally, so we have to kind of wait and see what the final consensus is. So how do you define right now sarcopenia? We need three things. Number one, we need muscle weakness. So we did this many years ago. It was a longitudinal study. We evaluated 120 individuals that came back to the lab 10 years after the first evaluation. We used the old Cybex device. I saw in some of your labs the Biodex, which is old also. And Cybex and Biodex do not exist any longer as companies, although the devices are fantastic. We talked about that this morning. And as you can see, if you look at the knee extensors and flexors, there was about a 1.5% loss per year, strength loss per year. But the upper limbs, the elbow flexors and extensors, about 1% in men, but no change in women. Now, this has been reported by other researchers. This is not an exception to the research in this area, and it's unclear why. The argument is that women maintain more physical activity with the upper limbs as they grow older than men. That remains to be proven, but nevertheless, the finding is out there and it's been repeated several times. So number one criteria for sarcopenia is muscle weakness. Number two is muscle atrophy, and I already mentioned that. You look at MRI scans on the bottom side of the scan of the slide. The one on the left is a healthy thigh. The one on the right is a sarcopenic thigh. You see the fatty infiltration and so on. By the way, the same muscle atrophy is seen in cross-sectional views of muscle fibers. I don't want to get into that, but it's not only atrophy at the macroscopic level, it is atrophy at the microscopic level as well. So this is the second element of sarcopenia. And the third one is a very functional determinant, walking speed. And a lot of people use 0.8 meters per second as the criteria. If you walk slower than that, either you have sarcopenia or you are a candidate to develop sarcopenia. And they have shown a very, very nice association with slow walking speed and dependency in activities of daily living, likely to be hospitalized, falls, and so on. So there is a functional element to this measurement. Now, why is sarcopenia so relevant from a clinical point of view? Because it is associated with all kinds of negative outcomes. Falls and fractures, impaired activities of daily living, cardiopulmonary disease, cognitive impairment, MCI, loss of independence, lower quality of life, and so on, mortality, poor prognosis in cancer. So the reason why sarcopenia is getting a lot of attention is because it's being used as a predictor. So if you have sarcopenia, you're more likely to have any of these negative outcomes. And if you're likely to develop sarcopenia, maybe we can intervene and make sure you have a lower risk of having any of these outcomes. So this is the clinical value of identifying sarcopenia early. Now, how do you do that? And I know this is a complicated slide, but I'll simplify the message for you. Number one, you identify candidates for sarcopenia, those who have unintentional weight loss, repeated falls, chronic conditions, all of those patients that come to your clinic with that kind of description, likely candidate to develop sarcopenia. What do you do then? Well, you do three things. You measure hand grip strength with a very simple device that I'm sure you have in your clinic. You measure physical performance, walking speed in the clinic, and you do a DEXA to measure muscle mass. So if you want to understand whether one of your patients qualifies for the diagnosis of sarcopenia, then you run the tests, okay? And according to the Asian group, if you have low muscle mass and low strength or low physical performance, you have sarcopenia. So you need two of the three criteria, but you need low muscle mass. If you have all three, and some people have all three, then you have severe sarcopenia, which is not something you want to see, okay? By the way, the WHO has included sarcopenia in the ICD-10 book of codes. It's M62.84, something like that. It's been there since 2016. So you can make the diagnosis in the clinic and actually bill for it. Now, how prevalent is sarcopenia? Well, this is a very important study. This was actually a systematic review done in Asia, again. And they look at 140 studies in different Asian countries with more than 156,000 individuals. And again, these are community dwelling individuals, not patients in a hospital. You go out to the community and you measure this. And the basic message is prevalence is around 16.5% of healthy, older, community dwelling adults. Okay, 16.5%. Possible sarcopenia, meaning they have some criteria, 28.7%. So two messages here. The incidence prevalence is high, but not every older adult has sarcopenia. If you want to look at this by country, these are the numbers. In Korea, 20%. Japan, 13%. Malaysia, the lowest, 8.6%. So significant variability among countries. Some data from the US actually suggests that in our case, it's between 12 and 15%. So it matches well with these data, okay? Now, this is a cross-sectional study. And as you know, cross-sectional studies have some weaknesses, especially when you deal with aging. So there's one longitudinal study of sarcopenia that was done in Korea. They follow, again, 746 men and 890 women over 2 years to look at real incidence, not prevalence, incidence. And again, the numbers are similar. 13.5% of men and 11.7% of women develop sarcopenia over those 2 years. So it really doesn't take that long for sarcopenia to evolve in this group of individuals. Now, there's a group that is a higher incidence of sarcopenia. You see the risk factors here: older, lower BMI, not higher, lower BMI, more comorbidities, which makes a lot of sense, and low levels of physical activity, which of course contributes to this. Okay? Now, I'm not going to get into a molecular discussion about sarcopenia, but I think it's important for you to know that there's significant so-called basic science research on the topic. And I want to mention some of the findings. Number one is that this is not about skeletal muscle only. So we got to understand this is a multi-system problem. Many physiological systems contribute. Starting on the left-hand side, microvascular impairments, subclinical inflammation, and this is probably one of the most important things. We know that these people have elevated biomarkers of inflammation, even though they have no clinical signs or symptoms of inflammation. Okay, so this is an important one and is being targeted for treatment of strategies. Reduced physical activity, periodic disuse. This is, hospitalization, 5 days because of back pain in bed and whatever. Poor diet quality, a reduction in many of the hormones, especially testosterone and growth hormone, impaired GI tract function, and anabolic signaling impairment. This really means that even though they have anabolic hormones circulating, the muscle is not responding to that anabolic stimulus. And there's a lot of research about why this is the case, okay? So the message is, this is a multi-system syndrome, condition, and so on. So it will manifest itself in muscle weakness and atrophy, but it's not limited to muscle, okay? And you, of course, know the fact that muscle is no longer a passive entity in the body. Muscle is also an endocrine organ. So there's a lot of substances that modify metabolism, inflammation, and so on that are produced in skeletal muscle fibers. So the fact that this muscle atrophy and weakness has developed from a mechanical force production point of view has a lot of metabolic consequences. Now, we've done some research at the more basic level. We biopsy the vastus lateralis using this technique. The reason why we have chosen the vastus is because the knee extensors contribute about 70% of the power that is needed to rise from a chair, a very basic activity. So if you want to get home today or to dinner, whatever, you're going to have to rise from a chair. And it is really your vastus and the knee extensors that do that for you. Also, it's an easy muscle to biopsy because there's nothing, no anatomical structure that is dangerous, I would say, close to that muscle. We divide the biopsy into bundles of fibers, and then we take individual muscle fibers here. We put them under the microscope and activate the fibers with calcium. So in this technique, we don't have a nervous system. We're stimulating the muscle fiber using chemicals, calcium, which is the way it happens in the human body. And the point is that this is a strategy to dissect out changes in muscle fibers from nervous system, brain, spinal cord, and so on. Now, there's one observation that I want to share with you. These are measurements of individual muscle fibers. We measure something that is called specific force. So maximal force divided by muscle fiber size, okay? And as you can see, older fibers have lower specific force. Older fibers in yellow have lower specific force. So the conclusion is that what is happening in older muscle is not an atrophy problem. This has nothing to do with a reduction in muscle size. This is about a change in muscle quality. The muscle is not working well. It doesn't really matter whether it is bigger or smaller. Something is happening inside the muscle fibers. And there is some research at the level of cells and molecules, and these are the three most important changes that people have reported. Number one, a reduction in the amount of myosin that, as you will know, it is the most important protein in skeletal muscle. Number two, changes after the protein has been synthesized, oxidation and glycation. And we have a lot of that going on with aging and also diabetes, by the way. And number three, the satellite cells of skeletal muscles, which are really the stem cells of muscles, do not work well. We lose muscle stem cells, and those that remain active are not really that great. Okay, so having said all of that, then what do we do about this? Is there anything we can do to intervene? And we do what nature does all the time. So here's a fellow weightlifting. This is strength training in nature. You have an animal here that is carrying another one. This is overloading muscles. That's what we do all the time in the gym, in fitness centers, in the clinic, physical therapy, and so on. So we have applied this concept that was published for the first time by Tom DeLorme in 1945 that some of you may be familiar with. This is the progressive resistance exercise concept. DeLorme was, by the way, was an orthopedic surgeon in Boston, and he was treating patients with polio and all kinds of muscle diseases. And essentially the concept is you overload muscles, in this case, knee extensors or elbow or whatever muscle group you're working with. You do it progressively, meaning that every week or every 2 weeks, you increase the load, the training load, and you do 3 sets per day per muscle group at a slow speed, 6 to 9 seconds per repetition, and I'm going to come back to that concept. And you do 10 repetitions per set. This is very classical training. This is not an experiment. This is traditional weight training. We use 60 to 80% of the 1 repetition maximum, which is the intensity of the training. Now, you may recognize this to be fairly high intensity, which is why when we have someone who's deconditioned and has not exercised for a long time, we start very low, 25, 30%, until we can get to 60 to 80%. You do 3 days per week, alternating days. And the reason for that is that when you go to the gym, you do a training session, you induce protein catabolism, you destroy muscle. And physiologically speaking, you need close to 48 hours to recover from that, which is why you wait 2 days before you do the next training session. Now, people go to the gym every day, but they don't do the same muscle group. Those who know how to train don't do the same muscle groups every day. Okay, you're smiling. That means that you're making that mistake, but that's not a problem. And then, of course, the total duration of the training has to be at least 12 weeks and hopefully for life. Now, we're not saying that this is going to stop aging, and this is an important part of the discussion. We're only saying we can reverse, slow down a little bit of that age-related loss. These 2 pictures published by this individual shows that even with strength training, he shows very clearly muscle loss, but he's still in good shape and willing and able to do exercise. Now, just to show you that, in black I have here, this is really one of those slides that you put together and make a little bit of a, I guess, trick, because this is not a single study. I decided to manipulate the data, put together data from different studies, just to illustrate my point here. In black, you have changes in aging in muscle strength and muscle cross-sectional area with 12 years of aging. This was the longitudinal study that I showed before. And then in yellow, you have the gains in strength and muscle area with 12 weeks of training. So I don't want to sound too simplistic, but the message is that part of the age-related losses have nothing to do with an inevitable biological aging process. They're associated with lifestyle, malnutrition, lack of exercise, and so on. Now, some people go to the gym and they don't do well. Some patients go to physical therapy and they don't really show gains. And this is a very hot topic right now. So some people respond the way they should respond, with gains over time. Others are extreme responders. They train for 2 months and they develop significant hypertrophy. And then we have this group down here that is being called low responders or non-responders. And there's a lot of research here, but the message here is before you conclude that there's a problem with them, why don't you fix your prescription, the recommendation how to do the exercise. Now, there is some evidence that some of these people simply have bad genes and that there may be a genetic issue here. So the genes are not responding to the exercise stimulus. This is, of course, there's a lot of debate about this. But the point is that not everybody will respond the same way. Now, let me come back to the issue of the speed of the muscle action. Because if you're here, this is what's called the Shibuya crossing in Tokyo. And I met someone this morning who spent 5 years in Tokyo. I don't see him here. But anyways, the point is that if you're crossing an intersection in a big city like Chicago, the issue is not to develop maximal force so you can cross the intersection. Issue is you have to develop a level of force quickly to avoid being run over by a car. And that by definition is power, not strength. This is an important distinction. And this is why in many cities, large cities, you have a clock that will tell you how much time you have to cross the intersection. And this is important because we have used that, concept to develop a strength training program that is different than the one I showed you before. In this group of individuals, we divided the exercise into concentric and eccentric actions. And in this case, concentric is when you rise up from a chair. Eccentric is when you sit back down. And what we do is we do the concentric part of the exercise quickly. This is the power element, quickly. And then you sit back down slowly. 2 more things about this. This was one of our NIH-funded studies. We actually compare this approach with the NIA recommendations, and they both resulted in increases in strength. But this one was much better in terms of increases in power and functional tests, which is really what the volunteers and patients would like to see. You tell someone you're going to get bigger muscle fibers, and they say, so what's the relevance of that? I simply want to be able to climb stairs and go outside and so on. That's the functional outcome. 2 more things about this. You can see that they are using a vest. This is a weighted vest. You can buy these in Walmart for $40, $45. And the vests have pockets, and you put the weights in the pockets. That's the way they do weightlifting. And also their hands are free. So they can use their hands to do other kinds of exercises or things. So it is a very nice approach to train individuals. Plus, they're training in groups, which brings in the social element of the rehabilitation program. Another important issue here with exercise is that you need to pay attention to one of the most challenging issues in older adults, and that is falls and the risk of hip fracture and mortality. And so this is a Cochrane review of 81 clinical trials, and they showed with this systematic review that exercise reduces falls and the number of people that fall. Now, an important element of this training is that in addition to strengthening, they had to include balance exercises, which is why they're recommending Tai Chi, because they can do the Tai Chi in and of itself has both elements, strengthening and balance. So that's why they're recommending this as one of the most important interventions. Of course, you can do this in the clinic, and you do exercises of strengthening and balance exercises together. Now, what else can we do? And here's the nutritional part. These are general recommendations that I put together, some of the recommendations from different papers. And the basic recommendation is increase protein intake. Now, this is a wide range. A lot of people are limiting this to 1.2 to 1.5. They don't go all the way up to 2. There's an element there, a medical element, that you have to make sure that the patient has good kidney function. Okay? But nevertheless, this is the recommendation, grams per kilogram of body weight per day. Now, you have to understand whether this is already in their diet or not. So you got to assess, evaluate the diet of the individuals. But if there is significant, I would say, limit in terms of the diet, then you should add a supplement. And many of those milkshakes that you buy in supermarkets have 15, 20, 25 grams of protein in a single drink. So there's a very nice, convenient, practical way of supplementing the diet with protein. Number 2 is that the key element is not any protein, it's the amino acid leucine. This is the one that stimulates muscle protein synthesis. So you got to make sure that you have the 2 and 3, between 2 and 3 grams per meal. Even distribution, meaning that you can balance the daily diet, breakfast, lunch, and dinner. And we used to think that we needed to have all kinds of protein after exercise. That is not true. You can do this in divided doses. And number 4 is that animal and plant protein are both effective, both. The only difference is that plant protein may have lower leucine concentration, so you may have to eat a bit more to get to the same level, but they're equally effective, okay? Now, we get into complicated combinations here, and I apologize for the slide. I'm sure you cannot read the numbers, and that is on purpose. The message here is that in real life in the clinic, we don't do exercise only or protein supplementation only. We combine them. That's the way to do it. And there's many recent studies that have looked at the combination as an intervention. So in this one, they combined resistance training and amino acid supplementation with significant leucine. And as you may know, this is a forest plot from a meta-analysis. And the important message is down here. This diamond that, as you can see, is to the right of the entity line here. The diamond shows that most studies demonstrate that the combination is actually good in enhancing hand grip strength and gait speed. So this is not about muscle atrophy and so on. This is about strength and gait speed. And so I think the evidence right now is pretty strong that we should combine these 2 interventions, okay? And then a bit more complicated is that now a lot of people, in addition to the exercise and the diet, they also take vitamin D and calcium. And they may be taking vitamin D and calcium for other reasons. But this particular study done in Korea showed that all of that together is also very good. And the outcome in this study is all the inflammation markers that I mentioned before. So they all go down with this intervention. Exercise, protein supplementation, vitamin D, and calcium. Of course, you could argue, well, I have no idea whether it is the vitamin D or the calcium or whatever. But this is a pragmatic trial. This is the way we do things in the clinic. So we should put it to a test. And I think the evidence is quite strong. Now, to conclude, I'd like to kind of get into something that everyone in science should do frequently, and that is speculate. What may come next? If you don't do that, you will never come up with a new idea, right? Or a new study, a new hypothesis. So we have 3 things that are being studied, tested, and that we simply speculate whether this is the answer to not only sarcopenia, but some of the age-related losses. The use of senolytics. I mentioned to you before that there is an inflammation problem. Where is that coming from? Well, coming from a lot of cells in the human body that stop replicating but do not disappear. They do not die completely. Those are called senescent cells. And those secrete inflammation or inflammatory markers. And so the idea of these studies is to actually eliminate those cells from the human body. Of course, this is all, at this point in time, experimental. And there's a group at the Mayo Clinic in Rochester, Minnesota, that is testing these drugs. Now, let me say again, these drugs are anti-cancer drugs. These are not experimental drugs. They are being used already to treat some types of cancer. What they're doing is testing the ability of these drugs to remove senescent cells. And this is already being proven in animals and in ex vivo human tissue, but not in patients. Now, you can imagine the challenge of doing this. How do you know where the drugs go to? If you want to remove senescent cells in muscles, how do you make sure that they only go to muscles or to the brain or whatever? So, number two is something that you're familiar with, stem cells, of course. Everybody is thinking that stem cells will be the answer for many of our health conditions. This is the person that won the Nobel Prize because he described the pluripotent stem cells. And to my knowledge, no one is using stem cells to address sarcopenia. But there's a couple of people looking at frail, older individuals. And this is, in my opinion, very far from becoming a clinical intervention. But nevertheless, I think it's worth looking into. Remember that stem cells of skeletal muscles die. We lose them as we grow older. And finally, something that you may be familiar with, gene editing. This is being used not only in the labs, but also in the clinic. There's a number of rare diseases that are being treated with gene editing, and one of them is Duchenne muscular dystrophy. So if you're doing this with Duchenne muscle, why can't we do it for sarcopenia? We'll see. By the way, I always say this, the two ladies that won the Nobel Prize describing this entity met for the first time to talk about their experiments and to have a cup of coffee in the old San Juan in Puerto Rico. I'm proud of that. But this is what a cup of coffee can do. You know, this is what you can do when you're, you know, close to each other and have a conversation about ideas on how to address an important question. There's a number of drugs that are being tested for sarcopenia, and this is a long list, and one that is getting a lot of attention is metformin, because it is being used to treat diabetes. And people say, well, maybe this is one that we extend lifespan, life expectancy. None of these drugs have been shown to work, but they're being tested. I don't have to tell you that the pharma industry has a lot of interest in this, because the number of people with sarcopenia, of course, is large, and they're trying to also include something that is called secondary sarcopenia, which is really muscle atrophy in chronic conditions. Now you can think about a market for that. Two final comments. Number one is that I've limited myself to sarcopenia in the context of aging, of course, and to exercise. But I don't have to tell you that life is more than exercise, and there's a lot of other lifestyle factors that contribute to longevity. This particular study was done in the VA system that, as you know, has a fantastic electronic health record. They looked at more than 700,000 participants, and they look at the factors, lifestyle factors that are associated with mortality. And as you can see, the more factors that the person had, the lower the mortality or the risk. And the factors are, not surprisingly, never smoking, physical activity, no regular large binge drinking, good sleep hygiene, good diet, minimal stress, positive social relationships, and no opioid addiction. something that I'm sure all of you recognize. Now, my final thought goes to the systems approach to this. We're talking about the level of the individual, healthy aging and things that may have an impact on healthy aging, but an individual by him or herself is not going to do this. So we need all of you, healthcare professionals, to become familiar with this and implement interventions. We also need the system to support those interventions. And finally, we need the political framework, policies that will facilitate the implementation of these interventions. Recognize aging as an important challenge for nations and societies. And that is not happening at this point in time from my point of view. So we need to make sure that people who are policymakers. My time is up. Yeah.
That just went off, as you said, policymakers.
And someone is listening to the policymaker may not be happy with what I just said. But anyways, the point is that we need a systems approach to this. It's not only patient by patient, but of course, I don't really have to tell you that. So anyways, the purpose of the presentation was to I guess, share with you some data, demographic data, that will put aging in your radar. Say, you know, this is an important issue, and the data are very clear, and it's universal. And it's you and me, our patients, and our neighbors, and family, relatives, and so on. Number two, that there's very clear age-related syndromes that have functional impact. Sarcopenia is one of them. And we know a lot about sarcopenia nowadays. There's a basic science element, physiological element, and also, of course, you know, integrative physiology evidence for this. Number four, I guess, is that we do have interventions that we can use right now. Exercise is one of them, although we have different types of exercise. Nutrition is another one, and vitamin D, calcium, and so on. And number five is that there is a lot of scientific interest, and there's a lot of research that is being done to understand this better and to come up with more relevant interventions and that may be more effective, I guess. So again, thank you very much for the opportunity to be here today. It's been fantastic to visit this place, and I'm really happy to see this group come together under the same roof and with the same kind of aim, scientific interest in mind. Thank you very much.